Good morning, everyone. Welcome to the Thursday, January 26th, Zero Suicide Learning Collaborative. So good to see all of you. Thanks for joining. Now, this is quite the busy time around the Office of Suicide Prevention, so I'm sure that's the case for all of you too. So really appreciate you taking the time out of your day to join us. If in the chat you could drop in your name, your organization, and if you're from a large system, again, if you could please provide that facility name too, that's how we keep track of who's joining us for these learning collaboratives. And our check-in question this morning is whether or not you made any resolutions or intentions for 2023, and if you have any updates to those. If you feel comfortable sharing, please feel free to put that in the chat. Or if you're not a person who likes making resolutions, I'd love to hear why too. I feel that, Heidi. No resolution. Life is too unpredictable these days. We're just rolling with the waves. Ooh, health in general. I like that. Practice mindfulness. That's a good one. Good morning, everyone. Again, this is the Zero Suicide Learning Collaborative for Colorado. If you could please drop your name and your organization into the chat so we keep attendance. And if you're from a large organization like UC Health or Centura, please also put the facility that you work at as well. Again, we're chiming in with if you made a New Year's resolution or intention for 2023, how it's going, or if you're just like some of the folks in the chat and you are just happy to be here. Ooh, Miranda, practicing your Spanish more, thanks Duolingo. That app is life-saving. All those little pings from the sassy owl, I love it. Awesome, thank you all so much for chiming into the chat. I love these answers. Lots of no resolutions, lots of the resolution is to just keep swimming. If you're just joining, we're going to give you a couple more minutes to chime in with your name and your organization into the chat so we can know who's here. Thank you so much for doing that. Thank you so much again, everyone, for putting those answers in the chat. Ooh, I really like that. That goal is to rest during the winter months. I've been big into the hibernation mindset these last couple months. I feel that. Thank you for putting your name and organization in the chat. We are going to go ahead and get started with today's session, which is going to be focused on trauma-informed care as suicide prevention. A lot of y'all I know have done really cool things in this area already. Really excited for our guest speaker today, Leah Jackson from UC Health. Is going to be talking to us about trauma-informed care and how that might play into your ZS implementation. And I'm just going to share out some OSP related resources and updates in this area. But as people are still trickling in and putting their attendance in the chat, I'm going to toss it over to you, Leah. Thank you so much for being here.
Thank you so much, Conlin, for inviting me to be here and giving me this amazing opportunity to speak and share about something that I'm very, very passionate about. So I will go ahead and share my screen. said, I am Leah Jackson, and I work at UC Health Memorial Central as a behavioral health clinical therapist, and I primarily work with patients who are admitted to the floor for a medical condition, needing some additional help. So to begin with, I will go ahead and give you a hard definition of trauma and then discuss a little bit about the prevalence of trauma. First and foremost, it's important to know that trauma does not discriminate, and anyone could be impacted by trauma. And when we talk about trauma, it's basically a negative event or experience or a series of them, which someone comes into contact with and it impacts their ability to function. And this can be it can be experienced in many different ways. And it's also important to understand that trauma is subjective. So what some people might think is a traumatic experience to them, others may not. And same with us. We might say, oh, this isn't really a traumatic event. However, in reality, it is to the patient or individual or whoever we are supporting in that moment. Some things to really understand when we're looking at trauma is how it was experienced, how it was caused, and what is the psychological meaning behind it, because there is some psychological meaning to it. Now, when we look at the prevalence of trauma, trauma is something that is kind of like we know happens, but is not necessarily talked about on a regular basis. And that right there in itself is a problem, right? Because we want people to be able to take advantage of resources that are available to help them process their trauma, be able to function and move on from it. And I will say one of the things that comes with trauma-informed care is the language that we use. So trauma-informed care is actually gradually being transitioned to trauma-responsive care, right? Because it's one thing to be informed and then another thing to respond in a trauma-responsive way. And then also, here is some prevalence regarding the trauma that we have out here in the United States. And so as you can see, about 70% of adults, which equates to about 223.4 million in the United States, have experienced some sort of trauma. In public behavioral health, 90% of clients have experienced trauma. More than 33% of children exposed to community violence will develop symptoms of post-traumatic stress disorder. Now, to further paint the picture of how relevant trauma is in everyday life and functioning, we need to take a look at it from a suicide perspective. So regarding suicide, someone who experiences trauma may be at an increased risk of suicide. 27% of people diagnosed with post-traumatic stress disorder have attempted suicide, and 54% of suicide among people living with PTSD, post-traumatic stress disorder, were directly related to symptoms of PTSD and not co-occurring disorders. So that kind of puts in perspective of like how relevant it is and how we need to put interventions in place and prevention in place so we can not only prevent trauma, but also as it pertains to suicide. So the question then becomes, why trauma-informed care? What is the rationale behind it? And the first and foremost thing that everyone needs to be aware of is that trauma-informed care, trauma-responsive care, is a tool that we as providers can use to facilitate the healing process. Facilitating that healing process is imperative to recovery. Recovery in the context of not only substance use disorders, but as well as mental health disorders. Okay, so always keep that at the first forefront of your mind when you think of trauma-informed care. Okay, it's there to facilitate the healing process. In addition, there are many benefits when it comes to patients, behavioral health providers, and organizations. So first, with patients, trauma-informed care reflects a compassionate view of their experience. It creates a sense of safety and identifies their resiliency. Resiliency is key because not only does it take their experience and identify their strengths within that experience, it further again facilitates that healing process. Secondly, for behavioral health providers, trauma-informed care emphasizes the importance of maintaining and obtaining trauma-specific skills and knowledge. It guides behavioral health providers with recognizing trauma, even if the client doesn't recognize it or identify it. There's so many times patients who I work with will tell me something that they have experienced and they will not identify it as trauma. However, me knowing, this various symptoms of trauma and the impacts of trauma and having those specific skills and knowledge related to trauma, I can clearly identify that that was a traumatic experience for the patient. And then it also acknowledges the risks of re-traumatization. And we'll talk about this a little bit more, but the ultimate goal is to prevent re-traumatization. We do not want to put clients or patients in a place where they, A, cannot be themselves, and B, get the support that they need to move past what they are experiencing. And then lastly, trauma-informed care is cost-effective. It minimizes risks and ensures decisions are made in the best interest of the patients. So this is really looking at, policies and procedures. Are we implementing policies and procedures that facilitate that healing process and do not re-traumatize? And if not, what do we need to do to make sure that that happens? Because we do need to make sure our organization is in alignment with trauma-informed care practices in all aspects. So to give you a base of the basics of trauma-informed care, there are 6 specific principles that are involved, as well as the 4 R's, okay? So trauma-informed care starts with the utilization of these principles, which include safety. And when I say safety, I'm not talking about just generally safety. We're talking about not only the psychological part of it, but also the physical part of it. So you want to create this sense of safety in the physical environment and the psychological environment. And there's so many different creative ways that you can do this, okay? Secondly, trustworthy and transparency. And what this looks like is people are involved in the decision-making process, and the process is shared and transparent. This further builds that trust between not only our team members within the organization, but with also the clients and communities that we're serving. Next, there's peer support. Peer support is fantastic, and many of you may have already seen a lot of efforts by SAMHSA push out grant money for peer support programs. But what peer support does is it aims for that safety, that hope, that trust, that connection to recover and heal. And the idea here is speaking of trauma-informed survivors to trauma-informed thrivers, okay, because people are thriving. Next, we have the collaboration and mutuality, where people come together and balance power. Empowerment, voice, and choice. It builds on power that people already have, even if they don't recognize they have it. Us as behavioral health professionals do recognize patients' innate strengths. And part of our guidance or how we support is to guide them to recognize their strengths and use them. And then also we have to take into perspective and consideration the cultural, historical, and gender issues associated with the experienced trauma and how we implement measures and provide services that can support them. One thing that I will really encourage everyone to consider is further exploring cultural humility. Cultural humility is an ongoing self-critique on how one's own background and the backgrounds of others impact various aspects of life, because it does. What this includes, cultural humility, is balancing power, developing partnerships, advocacy, and institutional accountability. So that in itself, you can see, is in alignment with the principles of trauma-informed care. And it further helps us go from cultural competence to really exploring our own biases and how that comes into practice, and how we can further implement measures to make things better, make treatment better for all people, regardless of any type of race, ethnicity, status, etc. Okay. So the 4 R's of trauma-informed care include the realization. So you understand the impact of the trauma for the individual. Okay. You recognize signs of trauma. And one thing to think about when we're talking about the signs of trauma, it's not just kind of like your standard, criteria for PTSD or ASD or anything like that. Some of these signs can be viewed as non-compliant. Well, this patient isn't taking their medication. This patient doesn't want to participate in physical therapy. This patient doesn't want to participate in care. It could come in the form of yelling. It can come in the form of being combative. I had a patient who the nurses contacted me about, who they said, she's just not participating in her care and we need to put a plan together for her. And I went up and I spoke with the patient. I learned about the patient's story. And the primary concerns with her were she wasn't eating, she did not want to go to palliative care, and she wasn't participating in physical therapy. So I asked her, I said, so what comes up for you when, you are choosing not to eat or anything else like that, physical therapy and palliative care? And when you sit down and you get a chance to learn people's stories, something amazing happens. And one thing that she mentioned was, well, I don't want to go into palliative care because my mom died in palliative care. So then when you hear that, you're like, wow, okay, so that in itself could have been a traumatic experience for her. And that makes sense. Regarding the food, she says, they're trying to make me eat all these large meals and all I want is soup or cream of wheat or something simple. Well, that, and not only that, but she had actually some injuries to her arms, and so she couldn't cut her food or open juices. And she also mentioned that. She's like, and I need help with some of these things. That too is a reasonable request. And then lastly, regarding her physical therapy, she says, I don't want to do physical therapy because I'm afraid to fall. I have fallen before and I'm afraid to fall again. And if they want me to do that, they're going to have to get me my walker. Wow, another reasonable request. So we put a plan together for her in a way that was supportive of her and her needs. And as we know, patients are the experts of their own lives. And so with a little bit of listening and asking and coming from a trauma responsive perspective, we were able to set things in place to further support her on her goals. So hopefully that puts in perspective for you of how to recognize the signs of trauma, which come in various ways. Okay. Then we also have response, how we respond, which would be according to the principles previously discussed. And then, as I mentioned before, resist re-traumatization. And so what this might look like is creating an environment that prevents re-traumatization and builds safety and maintains that safety. Okay, so it goes back to like the psychological trauma and, the psychological safety and physical safety. Okay. So now we'll talk a little bit about trauma prevention and outcomes in the context of the ACEs study. So for those of you who may not be familiar with the ACEs study, it was a study that was conducted by Dr. Vincent Folletti and Dr. Robert Anda. Dr. Folletti was from Kaiser Permanente and Dr. Anda was from the CDC. It was a study that was conducted in the 90s to understand the relationship between childhood trauma and behavioral and medical problems in adulthood. So it really takes a look at that biopsychosocial perspective. Um, and so when we look at things like that, if you go to the CDC Vital Signs, you'll actually see what it looks like to prevent that. And see what can happen when we work from a prevention perspective. But one thing that I want to point out is people who experience some form of trauma tend to have comorbidities as they get bigger. So that what that can look like is depression and diabetes, or PTSD and anxiety, and even add on to things like that, such as substance use and so forth. Okay. When these adverse childhood experiences are prevented, and that's what the ACE study stands for, there is a large reduction of health conditions, a large reduction in negative outcomes in adulthood, decrease in health risk behaviors, and then also a decrease in socioeconomic challenges. Okay, and just to give you an idea of what that looks like, is 1 in 6 adults experience 4 or more types of ACEs, adverse childhood experiences. 5 of 10 of them, at least 5 of the top 10 leading causes of death are associated with ACEs, and 44% preventing ACEs could reduce the number of adults with depression as much as that 44%. Okay, and so in thinking about prevention, 21 million cases of depression could be reduced. Okay. Other health conditions include decreasing 1.9 million cases of heart disease. Like, that's huge. And in thinking about obesity, 2.5 million cases can be decreased. So really focusing on prevention of trauma-informed care is imperative to not only the psychology of someone or how they're interpreting the world, but also their health conditions as they get older and the different types of things that they experience. Okay. And so you probably are asking, what is part of the solution? And part of that solution includes trauma-informed care, trauma-responsive care. Working to prevent trauma should be our number one priority because there's so many different forms of trauma that happened from an individual level to a community level to a systems level. Okay. And so it's important as us as providers, we come together, we create trauma-informed organizations and communities, so that way we can prevent trauma and decrease exposure, decrease attempts of suicide, and so forth. What that also might look like is strengthening economic supports to families, promote social norms that protect against violence and adversities, ensure a strong start for children, so making sure they have access to their basic needs, but also a positive adult in their life. We want to teach different skills to families, children, adults, etc. And most importantly, we want to make that connection, because that connection is what saves lives. We want to intervene to lessen immediate and long-term harms to people. And a big part of that is implementing trauma-informed care. So I have my references here and then some additional resources. And to just briefly go over the resources, the Addictionary is a recovery research institute, which actually provides trauma-informed care language, which is amazing. And so as you're going through that, it actually says things like stigma alert. Instead of using this, use this, okay? So then we have some stuff about preventing child abuse and neglect according to the CDC, different learning materials related to trauma for SAMHSA, more information on the adverse childhood experiences study that we briefly spoke about, as well as the ACEs infographic that tells you what prevention could do. There's also a link furthermore on what cultural humility is, which I highly, highly recommend everybody explore further, because that will also get us a lot further in being trauma responsive, but also identifying our own needs as providers and what those needs and perspectives and supports mean for our services that we provide. There's a trauma infographic from the National Council on Behavioral Health. SAMHSA is fantastic. They actually have tip 57, which is a trauma-informed approach to implementing trauma-informed practices. And then there's also just a whole bunch of other digital products once you go on here to the website from SAMHSA, and how to implement cultural competence is what they focus on. But like I said, I encourage you to go beyond that to cultural humility. And then lastly, if you yourself are interested in taking the Adverse Childhood Experience Questionnaire for adults, I have that link there. And just note that the higher ACE score that you have is the more likely a person is at risk for negative physical and mental health or behavioral outcomes. Okay. And so that concludes my presentation. Let me see. I'm wondering, what questions do you have for me?
Thank you so much, Leah. We had, I don't want to jump in. Everyone's welcome to come off mute, but had a couple of things come in the chat. One, a logistical question. Curious about SAMHSA's peer support program resources. I'm happy to link those in. I know you mentioned that briefly, Leah. Definitely happy to follow up with some of those.
Okay, perfect.
Another was, I've heard lots of discussions regarding children who were subjected to live footage from 9/11. If that has affected them as adults as an ACE. I responded to that mentioning vicarious trauma, that witnessing traumatic events can be traumatic in and of itself as well. Linked in the tip 57. And another comment came in about the generational aspects of ACEs and trauma in general, how trauma is passed down from generation to generation as well. Definitely important to take into account that historical lens too.
Absolutely. And that historical and generational lens is also part of culture, right? And so that's further why we need to make sure that we're incorporating and implementing that cultural humility piece within the trauma responsive care that we're providing, because ultimately the care that we provide is going to need to be in alignment with their culture. Otherwise, they're going to disengage.
Yeah, 100%. Thank you.
Yeah, thank you.
With our remaining time, have some slides here because zero suicide. Oh, Nicole, go ahead.
Thanks, Conlon, and thanks, Leah. Great presentation. I know the targeted audience is mainly the medical providers who are implementing zero suicide, and I love the resources. I'm just wondering if you recommend, of those resources, if there's an additional work. I am the project manager of the Suicide Prevention Collaborative of El Paso County. So we have all different types of stakeholders: law enforcement, faith-based community, educators, policymakers, and we really want to start shifting that culture. So while it is wonderful that our providers are being more trained in this, we want to start talking about it more with our teachers and our faith community and our law enforcement. Is there a particular resource that you shared where they might not be a medical provider, but just start to think of that. We're trying to shift this conversation to community health. El Paso County, isn't in some areas the same place culturally as maybe the Denver metro area. So even just like talking more about trauma-informed care as suicide prevention, just wondering what resource you may recommend that the audience isn't necessarily a medical provider, but still important to share.
Yeah, great question, Nicole. So one thing that I might recommend for you to take a look at is the tip 57, because on there it really talks about how to create a trauma-informed organization, but that also goes further into how to create trauma-informed community. And so it starts to talk about like this is kind of what it entails. And then from there you pick out like, okay, so this might be how we can approach talking with community members. This is how we might be able to approach talking with law enforcement. Because remember, it really has to align with like their profession, and it needs to make sense for what they do in their scope of practice. And so I would recommend starting with tip 57, and then it's part 2, and then just building from there. Like, what would this look like? And so I think that would be a great starting point.
Thank you. I already Googled that and have it pulled up, so really appreciate that.
Awesome. Thank you, Nicole.
Thank you.
Can definitely follow up with some resources in that department too. Laura, yeah, go ahead.
Yeah, hi. I'm Laura Dykes with Colorado Coalition for the Homeless, and we have been a trauma-informed care organization for a long time. And so kind of moving past kind of beginner stages. And one of the things that I see that is really complicated related to trauma-informed care is when the training is really not there for the staff when they start. People misinterpret trauma-informed care as being nice. And sometimes being nice means not sticking to boundaries and not keeping things safe. And when we try to kind of correct to say, trauma-informed care is about understanding where people come from. It's not about being nice. Do you have any recommendations for kind of taking an organization past beginner stages trauma-informed care and into kind of a more, how do you keep people safe? How do you stick to boundaries while being trauma-informed?
Yeah, absolutely. So one thing that I would recommend, and I'm actually doing this because here at UC Health, we are working towards efforts to becoming a trauma-informed care hospital, and we're piloting on 2 of our floors. So one place where we started was conducting a needs assessment. And so what that really looks at is what are the perspective of our team members? What do they feel like they know? What do they feel like they don't know? And then based on that, we create a training to meet their needs. And so, for example, if you give this needs assessment and something in there is like, it says something like regarding boundaries, they don't follow boundaries or whatnot, then that might be something that you want to focus on your training. And then even, I know you mentioned that it's kind of like going past the basics of trauma-informed care, but I'm wondering maybe if that's where they need to a refresher course, because that is a place where we do need to implement those basic principles, because setting those boundaries is definitely part of the trauma-informed care response. For example, with people who are living with symptoms of borderline personality disorder, we definitely need to make sure that we're implementing those boundaries and implementing them from a way that is based on their strengths. And so there's various ways that you can go about doing that and kind of moving past that. But one thing I will say is implementing that needs assessment. And there's different ways that you can go about it. There's one for managers and there's one for frontline team members and so forth. So, that would be my first recommendation, and then just focusing the training specifically on that and how they can go about making sure that they are creating that sense of safety. because that is part of safety, creating the physical and safety environment. And one thing that I'm trying to transition to is something that we always call like the safe space, but instead of it being safe, changing it to that brave space, because patients are brave to share their stories with us and go there with us. So that would be kind of like my recommendation of it.
Thank you.
Yeah, thank you.
So much. I see you've had your hand raised.
Me?
You got it.
Okay, thanks. So Leah, I work in the North region for UC Health, and I was sharing with Conlon through an email that several years ago, the EMS up here, the group up here, were granted money to pay a consultant on the outside who helps form a peer support program for them. And then the ED up here got to tap into that as well. And I know how much they paid her for EMS. So I can just imagine how much more when they added the ED on there. So it's not feasible to continue to pay this person. Do you guys have a peer support program down in the South?
So that's great. So we have a peer support program as far as like, team members who are experiencing.
Oh, like a debriefing.
So not a debriefing, not for debriefing.
Okay.
I will say, for our patients, we do have connections with Serenity Recovery Connection, and they actually stay here and they will go meet with patients and provide that peer support to them. So yeah, but as far as like a debriefing or anything like that, we don't have that out here just yet.
Okay. And then my other question is, oh, I just lost it.
That's okay.
Shoot, what was it? Oh, about the ACEs for adults.
Mm-hmm.
You think about bedside nursing who are dealing with horrible situations, the ED and the ICU in particular, and even some of the units as well, because we get those dementia patients who just aren't thinking clearly and they become quite assaultive. But do you recommend that like bedside care staff do that so that they understand what some of their triggers are?
Do I recommend that they implement trauma-informed care?
No, do that ACEs survey for themselves to really get a better idea of what some of maybe some of how their experiences are tapping into maybe some transference that's going on as well.
Right. Yeah, I think that would be great, and the thing about it is that ACEs score is actually specifically for like the individual, right? So it's not going to be shared with anything unless they choose to share it. It can definitely provide them insight as to what may be coming up for them in the moment when they are working with a patient who is yelling. They are working with a patient who experiences, are just doing something that triggers them, what we call triggering to them. So it can give them insight to their own experiences. And I think that is why I really encourage people to implement cultural humility, because that is an ongoing self-critique of their own biases and what comes up for them in providing that patient care. Because one thing that we often talk about here is, we all have, some preferred populations and some non-preferred populations. And nonetheless, our goal is to provide the best care possible. And we must identify these biases and seek supervision regularly and ongoing. So that way it doesn't impair our ability to provide that quality patient care. So I think, you know, if a person would like to take the ACEs, you know, definitely could contribute some insight, and really practicing that cultural humility along with that will be key.
Thank you.
Yeah.
Thank you so much for this great discussion around where you're at, questions you have. Totally see those with like more ongoing relationships with patients to take a look into what trauma-informed care trainings and treatment options are available. I think that's a great segue to the remainder of today's chat. And Elise, I want to flag your comment in the chat. Among many organizations, they fail to make sure staff feels safe, but have an expectation that the staff will provide a sense of safety for clients. I really wanted to call this out and flag some more zero suicide specific resources and training available in trauma-informed care. So I'm gonna go ahead and share my screen again. Are y'all seeing this slideshow now? Awesome. So we know, like you just mentioned, Julie, and like you're saying, Elise, that healthcare workers experience stressors and trauma as well by virtue of the work that they're doing. That can include repeated exposure to death and dying, workplace violence, emotionally draining work, lack of support, acknowledging human limitations, and time of extreme work hours, uncertainty, intense exposure to critically ill patients. Can also be contributed to by lack of appropriate rewards, whether that's financial, social, or intrinsic. That lack of connection with others in the workplace. So I really appreciate the discussion around peers and what those structures could look like in the realm of trauma-informed care. A mismatch between personal values and what leadership or the organization is spouting as what their mission and their drive is. Some possible antidotes that I know our zero suicide grantees on the chat have used in the past, but is also generally recognized as emerging best practice, continually evaluating the appropriateness of existing behavioral health and well-being programming and support resources. Thinking about how you're accounting for psychological safety of staff through those debriefing, sentinel and emotional events in a non-punitive manner, not punishing folks for sharing where they're at. We'll definitely share out some resources after this call for this debriefing process and what some structures around that could look like. An important component of that is whether or not staff have a means of even providing feedback after these events. Again, providing staff support while addressing immediate concerns we are all facing, those shortages in staffing, burnout, managing stress, especially those job-related stressors that we know can lead to repeat and ongoing traumatization. And then again, like Leah has been centering today, is committing to providing all staff with that culturally relevant behavioral health treatment. What's going to make sense for you, given your experiences and your history? Just want to, again, share some discussion, but first, sharing some ideas for zero suicide implementation, what this can look like. So like Leah mentioned, screening for those ACEs and current trauma as part of assessment and intake, providing trauma-specific treatment on-site or through community linkages, leveraging CAMS, that collaborative assessment and management of suicidality that the office sponsors, training staff in both zero suicide and trauma-informed approaches. I know many of our grantees have new hire orientations that include a training component specific to trauma-informed care. Again, incorporating that peer support and centering lived experience, seeking to build those trusting, respectful relationships in care. And again, that focus on well-being for staff and patients alike. Wanted to flag, again, some specific training and resources for this. The Zero Suicide Institute has a trauma-informed care webinar specific to the Zero Suicide Framework. So the goals of that training are to explain the prevalence and impact of traumatic stress and its relation to suicide, describe the similarities of zero suicide and trauma-informed care, and how to embed and braid both of these initiatives together. That webinar is actually in part hosted by Leah Harris, another expert in this field, a lived experience advocate, and a peer in mental health. So definitely recommend accessing that webinar. some hospital-related resources, evidence-informed interventions for healthcare workforce relevant to trauma. You may have seen recently SAMHSA's Adapting Evidence-Based Practices for Under-Resourced Populations guide. Again, very helpful in thinking about how or the extent to which your care is culturally responsive. Some folks on the Office of Suicide Prevention team, Hannah, Jasmine, and Kaylee, released a worksheet based off of this guide that can be used step-by-step, walking you through that guide, more actionable, like a strategic planning document. If you're interested in receiving that, please feel free to reach out. The National Council for Mental Wellbeing, also this last year, released an entire toolkit, webinar on trauma-informed care screening and assessment, linked here. Emergency care resources. And then also wanted to flag our resources for after a suicide loss on the Office of Suicide Prevention website, just because we know how important it is to respond comprehensively after a death by suicide to prevent that traumatization or re-traumatization for those affected. So just wanted to flag some tangible resources. Nicole, I also appreciate you bringing in that community lens. I will add some of those resources to these slides as well to share out. But I think with our remaining time, I would love to hear some discussion based on these poll questions that Leah posed, and my own thinking as well. What changes your organizations have made in the last 5 to 10 years to provide trauma-informed care, and whether or not those approaches are aligned with what you're doing for zero suicide or what that looks like. So definitely interested to hear what folks have to say in the chat. Feel free to come off mute again as well. But definitely lots to be thinking about in this area.
Conlon?
Hello.
Hi, I just have a quick question. It's kind of connected to that, but a question when Leah, you had shared about the importance of language with trauma-informed care. And I know we've shifted from cultural competency to cultural appropriateness. You had talked about cultural humility. I just want to make sure we're using the right terms. So do you mind, in your view, that's the best term, cultural humility, and what is the difference between that and like cultural appropriateness?
Yeah, great question, Nicole. So cultural humility is more ongoing for the provider, right? And so for myself, what I'm doing is I'm recognizing my own culture. I'm recognizing what comes up for me in my practice as a therapist. I'm reaching out for support when I need support. And I'm understanding how my background is impacting me in all aspects that I'm experiencing. Likewise, I do the same thing with patients. With every consult I go on, the first two things that I ask them are, I mentioned is, tell me about your strengths. What cultural considerations would you like us to be aware of? Because that is a part of their strength. And then as I go on and start to gather the mini psychosocial, I start to learn how their culture has impacted them from in the mental health perspective, substance use perspective, and the sociological perspective. And so that is why my preference is always to approach different people and stuff like that from a cultural humility lens, because it allows for that exploration between myself and the individual, and also how we can both use our strengths to come together and work together to meet the patient's needs and also, what I need. And so cultural humility is great. And then it just depends on kind of like what context you're talking about it. Because if you're talking about being knowledgeable about different cultures and things like that, then you would probably refer to it as cultural competence, and then there are other forms of cultural aspects that we often hear. But once I learned about cultural humility and the advocacy that it's a part of, and then as well as balancing that power in institutions, I'm like, this is totally in alignment with the principles that we are trying to implement within trauma-informed care. And so in my mind, like, why wouldn't we? And so it makes that connection. So that's kind of my perspective on it.
Thank you. I really appreciate that. I agree.
Yeah.
Thanks.
Thank you.
Connellan, it's Robin with UC Health, and you had asked how we're incorporating it with our zero suicide. So we're lucky enough to have Leo in our building and to get to have her to help teach. And so we're trying to incorporate that into our staff along with QPR. And like she said, we're starting with 2 units, and our hope is to move forward with other units. And so teaching trauma-informed care along with QPR and our other zero suicide trainings, it's been amazing. And again, we're so lucky to have her.
Thank you, Robin. I will say I am so thankful to be part of an amazing team here. And, you know, Robin has guided me with a lot of things. And I do also want to point out that these principles and these 4 R's, and then there's also 3 E's, and there's other parts of, you know, trauma responsive care. But one thing that I really want to emphasize that was brought up earlier was that those also apply to our team. We cannot implement trauma-informed care or responsive care if we do not have a team that is also taken care of in all those components. And so that speaks to that mutuality and collaboration piece as well.
Thank you so much, and for being leaders in this area too. It really is vital. And trauma-informed care approaches go hand in hand with suicide prevention ones. So thank you both. Really appreciate that. A comment from Stephanie in the chat from All Health Network. All Health has internal trainers and consultants for IFS and EMDR. Trauma-informed care is a required training for new employees. Love to hear it. We have changed language in our EHR for documentation. And someone responded to that, Nathan, asking for some more details of how and what you're training your new employees, if they're willing to share that out, for use at Centura and Mercy Hospital in Durango. Stephanie, not sure if you feel comfortable coming off mute or if you'd rather connect offline, but just wanted to flag that in this space too.
Thanks, Colin. I'm happy to share what I know and then can email out additional resources. So trauma-informed care is a specific section of training in our NEO in one of 2 ways. One, they're literally talked to about it from a couple of different lenses, including culture. And then also it's an online training that they have to complete as part of a requirement for being a new employee. I'm happy to send out more details, and I will put my email in the chat for anybody who's interested.
Thank you so much, Stephanie. Really appreciate it. Had another comment come into the chat about documenting patients with history of trauma and being aware of a potential relationship, guessing with current treatment options or current health status. Definitely worth having that in the notes, as Laura mentioned as well, for a particular patient, having that baked into your screening and assessment in your electronic health record. Yeah, if anyone in this chat has experience embedding some of this information into their electronic health record, would definitely welcome you to come off mute and share how that was done, any successes in doing that, or any barriers you experienced too.
We have next gen, and so we made a customization to our trauma section of our behavioral health and supportive services histories to include history of traumatic oppression as a checklist related to trauma histories. And then we add, it's there for case managers, peers, behavioral health staff, nurses, and have really great response from the staff. So then we actually met with our next gen, our provider next gen, with the executives related to the development of the behavioral health EHR development team to try to talk them into doing this across the country. And they are working on it for their next rollout, which we were really excited about. Then we also added something related to difficulties related to like cultural assimilation, to kind of speak to more like immigrant experience and impact on related to trauma and added that later. So it's been really helpful to have better documentation. And I think the big thing is that in that trauma-informed way, every time a staff person sees those choices in their EHR, they have to stop and think about it for a second, and then maybe, you know, talk to the client about that, about their experience. So we've really been excited about doing that.
Thank you for sharing. Definitely see the value in that and that more robust documentation around these things. Super exciting that that's happening at a broader scale now too. Congrats. Amazing. That made me think there's this resource that came across from the MHTTC regarding newcomers to the United States and all the associated health status concerns that might be associated with that. I will flag that in a follow-up email as well for y'all, just because it's definitely related. With our remaining 3 minutes, thank you all so much for your time today. Just wanted to share one last round of OSP related updates. We will be having another Zero Suicide Academy in 2023. Please stay tuned for dates for that 2-day experience if you or any of the partners you work with would like to attend. We'll also be having a 1-day Zero Suicide workshop. It's basically a briefer form of the Academy in a 1-day format. We will also be hosting 3 other brief cognitive behavioral therapy workshops in 2023. And we have our ongoing relationship with CAMS, the Collaborative Assessment and Management of Suicidality sessions. So definitely stay tuned for those opportunities. Thank you so much again, everyone, for being here. Our next session is going to be February 23rd, 4th Thursday of the month from 10 to 11 a.m. Same Zoom information as usual. In the meanwhile, we'll follow up with today's amazing presentation from Leah. Thank you so much again for sharing your expertise and your passion in this area.
Thank you so much for having me, Colin, and thank you everyone for taking the time to listen to my presentation. I am putting my email address in the chat box in case anyone has additional questions or would like any type of clarification or follow-up. So thank you so much, Colin.
Thank you, Leah. All right. I hope you have a great rest of your week. Yeah, what day is it? It's Thursday. Great rest of your week. A nice weekend. Good to see all of you. Thanks for the great discussion today. And I'll be in touch soon with the slides and recording. Appreciate y'all. Have a good one. Bye.